You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. And I want to thank all of you so much for joining us on this episode. Today, we're going to be discussing CAR T-cell therapy, including approved indications, key considerations when referring patients, patient preparation, toxicity management, and post-treatment monitoring. We're also going to be talking about not only the benefits, potential benefits of CAR T, but also limitations, as well as future directions and clinical trials in this evolving field. We're delighted to be joined by Dr. Jason Weston, who is a professor in the Department of Lymphoma and Myeloma. He is the lead of the Lymphoma and Myeloma Service Line, Director of Lymphoma Clinical Research, and Section Chief of Aggressive and Indolent Lymphoma at the MD Anderson Cancer Center in Houston. Jason, thanks for joining us.
I'm happy to be here. Thanks for having me.
So we have a lot to talk about with CAR T, but I want to start with a very general question. We've had CAR T for a few years now, but more than just a few. Your broad view of this, is it turned out better than expected, sort of as expected, not quite what we all hoped for? What's your 60,000-foot view?
Yeah, we've had CAR T cells now since 2017, 2018 were the first approval. So this is now a relatively mature therapy. And I think this has been better than expected, but in complicated ways. This is a therapy that has upended how we treat patients with relapse refractory, so far, B-cell malignancies. Hopefully we have more to come in terms of solid tumors or other cancers, but for the time being, mostly CD19 targeted therapies have been where we've had the home runs. And with mature follow-up, with more than 5 years follow-up from the early trials, we know that we're now, in my opinion, curing people that previously would have died of this disease. So it's been wonderful. The downside has been it's not available everywhere. It's a complicated therapy, which we'll talk about today in terms of the side effects and the treatment management, which requires specialty care. So unfortunately, only a minority of patients who might benefit from this treatment are actually receiving it. So good and bad.
Let me hone in on that, on two things you mentioned. One is the word cure. In my short academic career, but it was an article that I wrote on use of the word cure. We don't use it that much collectively as oncologists. So tell me about your use of the word cure after CAR T.
You're exactly right. We don't want to use that word prematurely or inappropriately. That can provide a false sense of confidence or of hope when we don't necessarily know for sure that the disease is gone. But we know for a lot of diseases that the time for the risk of relapse is relatively early after treatment, especially for patients with refractory or early relapsing disease. For large cell lymphoma, it's an aggressive disease, and we know after our chemotherapy, or CHOP, relapses tend to occur within the first 6 months, maybe 12 months, maybe 24 months, but beyond that, relapses are exceedingly rare. Historically, that was also true for autologous stem cell transplant, which was the de facto second-line standard treatment for a quarter century. CAR T cells have less follow-up, but now with more than 5 years follow-up, we see a clear plateau emerging in the same time frame that we saw for our chemo or for autologous transplant. Early responses can be lost. Sometimes patients do achieve a complete response, but then the disease comes back. But if we're 6 months out, if we're 12 months out, if we're 2 years out, we start to have an increasing level of confidence that the cancer is truly gone. And that word is an important word for our patients to begin to put the cancer behind them mentally, stress-wise, anxiety-wise, planning their life-wise. And so I don't use that word right off the bat. I think that's inappropriate to tell a patient 5 minutes after CAR T-cell or at the first PET scan. But if we are a year out, if we are 2 years out, I think that word is appropriate for the majority of patients who've had CAR T-cell. Now, that's true for aggressive lymphomas. For indolent lymphomas and for mantle cell lymphomas and for CLL, we still don't know the time frame where we might use that word. And so I don't think it's a blanket statement we can say for all patients for CAR. T cell, I do think that there probably will be patients with indolent lymphomas that might be cured with a CAR T cell, but will need further mature follow-up in that disease setting.
You also mentioned the issue of a small percentage. Let me ask you more about that. Approximately what percentage of patients who might benefit are getting CAR T? And what are the barriers?
Yeah, it's a really important question because this is truly a breakthrough therapy, but a very small proportion of patients who could benefit get the therapy. And that small percentage, I would estimate somewhere around 20%, which is, in my mind, an embarrassingly low level. But that's not due to physicians not wanting to give the therapy or patients not wanting to receive it. It's the barriers that you mentioned. The main barrier is the toxicities, which we'll go over here, I'm sure, later. But the barriers of toxicity mean that this cannot be given in every community oncologist office. This needs to be given at a specialty center that can manage unique side effects. That is barrier number one, is that many people don't have access to those specialized centers. They can't travel, they don't have the family support, they don't have the financial support to travel or stay at a center for up to a month. The second is knowledge. Many patients think the treatments that they could get with their local oncologist sound pretty good. Why would I travel all the way to get something else over there? And they may not understand, or their physician may not understand, the true breakthrough nature of CAR T cell therapy. So, those two barriers, the physical barrier of not having access to, and the mental barrier or knowledge barrier of not knowing the need to force access, those are the two main barriers that are keeping us stuck at somewhere around 20% of patients who might benefit from CAR T cell that are currently receiving that treatment.
Actually, I want to reinforce that. So I practice in Baltimore in a community setting, but it's challenging to get patients right nearby to go. We have two centers of excellence, and it's sometimes hard to get patients to go. From your point of view at MD Anderson, for a patient with, let's say, a diffuse large B-cell lymphoma who relapses, is CAR T the next line of therapy, or how does it fit in? And which patients would you think about it, and which patients would you not?
I think that the field has rapidly evolved. So now in 2025, in the first few days of this new calendar year, things are quite different than they would have been 3, 4, 5 years ago. And the field is moving quickly. So this is something that you want to make sure that you're keeping up with the latest data. And that's why you're joining this podcast to listen today. There were 3 large randomized phase 3 trials comparing patients with early relapsed or refractory large B-cell lymphoma. And here, early means within 1 year of frontline therapy or not achieving a response, refractory. 3 large randomized phase 3 trials comparing the old standard, which was platinum chemo, and if that worked, then going on to auto transplant, versus CAR T cell. And 2 of those randomized phase 3 trials were knockout, clear winner CAR T cell. The other one was a tie. And the 2 CAR T cells that are now approved for second line are Axi-cell, axicabtagene, and Lysocell or Lysocabtagene. Those 2 products are clearly superior to chemotherapy and trying to get to transplant. In those clinical trials, CAR T cell had a better response rate and a more durable outcome, and therefore, in our mind, it is the preferred second line therapy. Patients on the control arm who got chemo, many of them didn't respond to chemo and then went on to get a CAR T cell on third line as sort of a next step, the old standard of try chemo first, save CAR T cell for later. And in the Zuma 7 clinical trial, which looked at Axi-cell, we published that there's an improved overall survival, statistically significant improvement in overall survival for doing CAR T-cell as a second-line treatment as opposed to chemo first and then trying CAR T-cell as third line. So the answer to that question of what is the sequence, what's the best time to use a CAR T-cell for a patient who's after first-line therapy, either having disease that's refractory or early relapsing, the answer is CAR T-cell therapy. And that's why it is important to know what is the best treatment and to talk to your patient about why even a relatively short trip across Baltimore, it would be worth it to go to a CAR T-cell center for that chance of improved overall survival. And the second part of your question is which patient would you consider for CAR T-cell therapy? The answer is most patients. This is really difficult for community physicians to screen patients and know this patient is a CAR T-cell candidate or is not a CAR T-cell candidate. And my advice to community physicians is to refer your patient, if they're potentially eligible, to a CAR T-cell center to find out if they're eligible. Don't prejudge. We've treated patients at our center who are up to age 90, relatively fit, of course. These are not 90-year-olds going on 190 years old. These are
Right.
90-year-olds who are walking and active and overall quite healthy. But nonetheless, there's not an age gap here or an age cap here. Whereas with autologous transplant, nobody would have given that patient 2 cycles of rice in an autologous transplant. So CAR T cells are different therapy than what we thought second-line therapy was before, where there's really not an age cutoff for most patients.
Let's focus for a couple minutes on not just toxicities, but bad outcomes. I mean, is that the impression I get is it's not that common in CAR T, but I'd love your perspective on it.
Yeah, side effects for CAR T cell, we generally view it as you are in a bad situation with a really bad disease. And so they're not zero side effects, but they're usually worth it in the sense where the payoff might be a potential long term disease control or perhaps cure. And so, therefore, side effects are going to be viewed through a different lens. Whereas if this is a palliative treatment or not something that is going to have that long term payoff. So, side effects of CAR T cells, I think, are different than transplant, but they need to be viewed in the same lens where they have to be managed by a team that knows how to manage them. And if you refer a patient for CAR T cells, you're going to have a long term relationship with that CAR T cell center to continue the management of the patient after they get back from the acute toxicities. But the main side effects we worry about for CAR T cells are something called cytokine release syndrome and neurologic side effects. Those are the 2 main acute side effects that we see. But as you mentioned, for allogeneic transplant, there's a fear of non relapse mortality of people dying of the treatment from an allogeneic transplant. Unfortunately, that is still a concern for CAR T cells, although I think it's a lower risk than what we've seen for those treatments in the past. Patients rarely could die of those acute side effects we just mentioned, cytokine release syndrome or the neurologic toxicities, although with improved management strategies, thankfully, that's a very rare event to have a patient die, although I personally have had several patients die from CAR T cell side effects. I've had many more who've done well afterwards. But the unique side effect that I want to highlight for the listeners to the podcast today, which we've learned a lot of over the past few years after CAR T cells have been approved, is the late risk of infections. Patients with CAR T cell therapy have a compromised immune system, sometimes for a year, sometimes for longer. And the greatest risk for non relapse mortality long term after CAR T cells. This is not the first month. We're talking at year 1 and year 2. If your patient is back to see you in the community practice after having had a CAR T cell at a center like mine, you need to be on high alert if the patient develops an infection to manage that very aggressively. And sometimes we even prophylax against certain infections. So the acute side effects are one thing. The long-term side effects require team management from the CAR T cell center and the community physician.
Let me ask you about essentially, as you said, some patients it's 6 months or it's a year or it's 2 years prophylaxis. How do you judge or how do you gauge immunocompetency? And actually, what do you prophylax against if you're going to do so? And also, what infections? What should we be on the lookout for?
Yeah, certainly. Infections are a common risk for all treatments for patients with B cell malignancies. When you go after bad B cells, you're also hitting the good B cells. And that's certainly true for CAR T cells, where they will effectively wipe out any cell in the body that expresses the target, which is usually CD19. In the short run, not having B cells is usually not that big of a deal. And we know that because patients who've gotten Rituxan for 6 cycles of our chemo, they don't usually have a lot of B cells on the other side, but we don't see terrible infections happen right after a course of our chemotherapy. It's the prolonged B cell aplasia which begins to creep up on people, and they get risk of having infections because of lack of antibody production. So at our center and at many centers, prophylaxis is usually a blanket 1 year of treatment. And we often will prophylax specifically against zoster using valacyclovir. We'll also prophylax against pneumocystis using either Bactrim or Mepron or other medications. It doesn't really have a specific prophylaxis for that one, but usually it's Bactrim for a year. At the end of the year, we will usually measure a CD4 count, and we'll want to see that above 200 for us to feel confident that the healthy T cell compartment, the non-CAR T cell compartment, has fully recovered in a way that's going to provide appropriate immunity for the patient. Sometimes it's not, and often then we have a difficult conversation with the patient of keep going with these prophylaxis medications, and the answer of how long is, well, until the CD4 count recovers. And I've had several patients where we're several years into that and we're still doing those prophylaxis. I don't know if that's something that is still the same risk 5 years out versus 1 year out, but the majority of patients have had a very robust recovery at 1 year. It's uncommon to see a delayed CD4 count. Regarding the B-cell aplasia, you can measure immunoglobulins. So looking at flow cytometry in the blood to see the percentage of B cells that have CD9 expression, CD19 expression. CD19 expression is a surrogate for are the CAR T cells still active. What you really care about are their functional B cells, and measuring the IgG, IgM, IgA. That's certainly something that is commonly done post-CAR T cell therapy to look for production of antibodies. If the numbers are low, some people will give prophylaxis independent of if they're infections. Other times, people will sit back and wait and see if the patient develops upper respiratory infections or other chronic sort of smoldering infections, and then give prophylactic IVIG or treatment IVIG to help the patient recover. So those are the main things we look for: immunoglobulin levels, CD4 counts, and prophylaxing with IVIG and or Valtrex and Bactrim.
Got it. Thank you. When you're discussing CAR T with a new patient, I'd be interested because we don't sit in rooms with each other as clinicians. So I'd love to hear, how do you introduce CAR T? How do you explain the mechanism of action to patients? Also, how do you explain toxicities? What level of detail do you go into?
Yeah, it's a great question, and you're exactly right. It'd be wonderful to be a fly on the wall of some of our colleagues and see all the unique,
Yes.
good ideas we have of how to phrase things. But the way I do it for CAR T cells is I describe that our immune system is a powerful weapon that keeps us healthy and fit and prevents us from dying from all these infections we're exposed to all the time. And cancer cells do get eradicated by the immune system. This is how our body is able to make billions, if not trillions, of cells every single day, and we're not developing cancer on a regular basis. It's because our body wipes out these cells that have some genetic abnormality that don't look like the others and don't look like they belong there. Our immune system is able to take care of them. But when a cell escapes that immune surveillance and becomes a cancer, the cancer cells are hiding in plain sight. They're effectively the wolf in sheep's clothing, where they look similar enough to your regular cells that your immune system doesn't attack them, even though they're growing and potentially putting your life in danger. So what CAR T cells do is take a small portion of your own immune cells out of your body, take some blood, and weaponize those T cells so they can now see the wolf in sheep's clothing. They can now find the cancer that's hiding in plain sight. So we take some soldiers from your immune system's army, and we basically take the infantry soldiers and send them off to an elite boot camp. They now go from being the basic infantry to being the Army Rangers or the Navy SEALs, whatever elite fighting force you like to think of. But these cells go off to boot camp for a couple of weeks when they're being changed from regular T cells into CAR T cells. And then when they come back home, when they're infused back into your body, they grow rapidly. They're infused through the vein, they find the target, and they begin to reproduce and make more CAR T cells. And these new CAR T cells, when they're growing and dividing, are fighting the cancer, but they're also secreting chemicals into your blood. These chemicals are called cytokines, and that's what our immune system uses when it's fighting a battle, whether it's fighting a battle against cancer or it's fighting a battle against influenza or a bacteria infection. Similar chemicals are released into the blood to call for backup, to call for more T cells, more immune cells to get in the fight and help your immune system eradicate the enemy. And that is why the side effects of CAR T cells look a lot like the side effects of an infection: fever, low blood pressure, organ dysfunction. Those are all things you might have if you had a really bad pneumonia or really bad urine infection, or you were in the throes of CAR T cell side effects called cytokine release syndrome. Rarely for infections we get neurologic side effects. That's something relatively unique to CAR T cells, where these same chemicals that are released in the blood sometimes will cause the brain to have dysfunction. And usually these side effects are reversible, both cytokine release syndrome and neurologic syndromes. However, this is a really, really amped up version of an immune reaction. And sometimes it can be life-threatening, which is why we have to be monitored carefully in the hospital if this side effect occurs.
Any correlation between toxicity and benefit?
Yeah, it's an excellent question and one that the patients ask routinely of, does that mean if I get a fever that things are working? And we think the answer is yes. If you get a fever, that implies that the CAR T cells are active, that they're identifying the target, basically that the battle is on. Unfortunately, getting a fever doesn't guarantee you're going to have a response. Sometimes there could be a subclone of the cancer that doesn't express the target, and therefore it's not seen by the new soldiers that have laser sight heat-seeking missile to go after the bad guys. So having side effects does not guarantee a good response, although low-level side effects, not a bad thing to see. Conversely, if we have severe side effects, if we have grade 3, grade 4 cytokine release syndrome or neurologic toxicities, sometimes we think that could actually go along with a lower chance of long-term good outcomes. That having such an explosion of an inflammatory component might have a negative consequence, and that perhaps could be due to the underlying disease characteristics. Perhaps the disease is very aggressive or growing very rapidly, and the disease bulk going into treatment may have an outcome association with the risk of high-grade toxicities. Having a high bulk of disease implies you've got an aggressive disease, and so therefore that disease may be more refractory or more resistant to treatments in general, including CAR T cells. But so bottom line, we can tell our patients having a low-grade fever is not a bad thing, even though you don't feel well for a couple of days. But unfortunately, it doesn't guarantee that we're going to have a great response.
There's a lot of talk about bispecific antibodies, and I've got a two-part question here. Where do those fit into the treatment approach for patients with relapsed or refractory disease? My other question is, if someone's had a CAR T, does that impact either positively or negatively on other lines of therapy?
Bispecific antibodies are a wonderful new advance treating many different types of cancers, but specifically heme malignancies. There have been several breakthroughs and FDA approvals as a result. And many listening to this podcast may already be familiar with bispecifics, but very briefly, a bispecific antibody, bi as in bicycle, has two different parts. It's the part that grabs onto the cancer, and for most B-cell malignancies, that's either CD20 or CD19 is the target antigen, and grabs onto the T cell, and that's usually CD3. So the way I describe it to my patients is the left hand grabs onto the cancer cell, the right hand grabs onto the T cell, and says, I'd like to introduce you guys and pull you up close and personal, and you have an immune response similar to how you could get with a CAR T cell, where the T cell is directly identifying the cancer cell and doesn't have that antibody kind of pulling the two cells together. It's a wonderful new treatment, and it complements what we're doing with CAR T cells. But as of yet, we don't quite have the mature follow-up data or the confidence that responses are going to be quite as durable as they are with CAR T cell therapy. So there are not yet any data comparing these two treatments head-to-head. I wish we had a randomized clinical trial with one side having CAR T and one side having bispecific antibodies. We don't. So unfortunately, we're kind of extrapolating between data sets. But in my practice, I view CAR T cell therapy as a greater chance of having long-term good outcomes. And so if I had to choose between the two at a center like MD Anderson, I would prefer a CAR T cell therapy. However, bispecific antibodies have advantages in that they don't necessarily require the monitoring that CAR T cell does. And so theoretically, they could be available to a lot more people that may not be able to travel or may not want to travel to a CAR T cell center, although bispecifics still do have risk of cytokine release syndrome to a lesser degree and therefore do require special monitoring. So here in early 2025, the answer is that CAR T cells are usually considered our preferred second-line treatment. Bispecific antibodies would be a third-line treatment or potentially a second line if a patient couldn't get access to a CAR T cell because of logistics or they live in a country where they're not approved in second line or whatever the reason is. But I think that CAR T cells in my practice would be the option I would go to if I had both available. But clinical trials are looking at moving both of those treatments perhaps into a frontline approach, which we can talk about in a moment. But I don't think that we've seen the full extent of what CAR T cells or bispecifics can do for our patients quite yet.
You just mentioned, I think, something very, very intriguing, which is the idea of upfront therapy. Wouldn't it be amazing if we could move that field of treatment ahead another 10% like Rituxan did years ago, or more for that matter? But is it good enough right now, the data, to make it worthy of study? What's being done? And let me just ask you broadly, too, what are future directions?
Yeah. Wonderful. Thank you. So future directions, obviously, we're always trying to further improve how we can help our patients and hopefully cure more people of an aggressive cancer like diffuse large B-cell lymphoma. So specifically on that type of cancer, there is now a randomized phase 3 trial comparing one of the CAR T-cell products called Axi-cell versus our chemotherapy. And this is specifically in patients with newly diagnosed high risk large B cell lymphoma with an IPI score of 4 or 5. IPI is the prognostic index, the International Prognostic Index that we know from training years ago. It's still valid today. But if patients have an IPI 4 or 5, historically we've worried that they have a high risk of bad outcomes with our chemotherapy. And so this is a study specifically looking at that population where we think we could perhaps do better with the CAR T cell for that subset of the most high risk frontline patients. That trial is ongoing and we're eagerly anticipating results. But if the CAR T cells look as good as they have in the past, we're hopeful that perhaps could be a new treatment option for patients in the early disease setting. Patients are getting one cycle of our chemotherapy before they go on the trial. So if you're wondering how would that work if a patient were diagnosed and then has to wait to get a CAR T cell, they would likely get our chemotherapy as an initiation and sort of a bridging treatment before they got the CAR T cell. That trial's ongoing. There are several other studies that are planning to launch looking at novel CAR T cells in a similar design, including a CAR T cell called rapcabtagene autoleucel, which is a very quick manufacturing. So there are a number of studies that are looking at CAR T cells perhaps moving from third or even second line into perhaps first line treatment, which would be great to cure more patients. And then if we want to touch on it, there's a whole new field of using blood-based ctDNA or so-called MRD technology to identify patients with high-risk disease and using CAR T-cell as a way to perhaps eradicate that risk of relapse using MRD. So CAR T-cell research has not reached its crescendo. There's still a ton of things ongoing, and hopefully there's many more benefit to our patients coming forward.
Yeah, I have to say, I'm sort of shaking my head. Honestly, just thinking about the possibilities, it's shaking my head in positive ways. It's pretty exciting. I want to ask you briefly about myeloma. Anything, again, maybe a 30,000-foot view with CAR T.
Yeah, myeloma is obviously a very difficult to treat disease and requires specialty care. And thankfully, there have been an incredible breakthrough of new medications in the past decade, including CAR T cells and bispecifics. CAR T cells have definitely changed the landscape for patients with multiple myeloma. And there are multiple approvals in this space. And it is a wonderful breakthrough that can provide long term benefit for some patients. It's not yet something that we have a high hope is curative in all the patients who receive it, but is a great breakthrough for patients who've been resistant or had disease that's not responding to prior treatments. And I think the sky is the limit for moving CAR T cells to even earlier lines of therapy for patients with multiple myeloma. Many studies are showing promise in that front. Same for bispecific antibodies. There have been several approvals, which has changed the landscape because CAR T cells early on had some difficulties with manufacturing capacity. And so there was effectively a wait list for some patients to receive CAR T cells. Bispecific antibodies do not have that problem. They're so-called off the shelf, meaning you can receive a bispecific antibody on demand, not having to wait for manufacturing. So having access to both for multiple myeloma patients of bispecific antibodies and CAR T cell therapy has been an unlock to further improve outcomes for patients. And I think that we're just scratching the surface of what those treatments can do for patients with myeloma.
I'd like to talk briefly about handoffs, both from the community oncologist like myself to the CAR T center and vice versa. What goes into that handoff? What are some of the assessments you do, including psychosocial, and what happens in reverse?
When we get a new patient referral to our center for CAR T cell, we start with the idea that we want to do the CAR T cell, but we have to make sure it's the right treatment for our patient. And so we do a good assessment of their fitness, including their cardiac function, their effectively get up and go, their ability to be physically active and to tolerate side effects. But we also look to make sure they've got appropriate social support. Obviously, some patients have a large family or a big friend network that can help them if in times of need. Others may lack those resources. And unfortunately, that is something that we look carefully at because CAR T cells are complicated. And if you have to be away from home for a prolonged period of time, being monitored to see if you're getting confused, It's hard to report yourself if you're getting confused. By definition, you're confused. And so having that social support is a very key part of it. If patients don't have access to that, there are resources there. Sometimes we could have a caregiver stay with the patient. So it's not a hard barrier, but it's definitely something we look at for the psychosocial support to make sure that the patient has that caregiver support network that can help monitor in that time of need. So it's a physical as well as a social assessment that goes into CAR T cell therapy. And unfortunately, some patients, either the physical side or the psychosocial side, don't have a match for that. And when we consider other treatment options, but that's what goes into that first part of the handoff when patients are sent to our center.
And I wanted to ask you about the flip side of it. When patients are discharged, I know your center does a particularly good job with reconnecting patients to their care after allo transplant, for example. What's involved in the handoff back to the community for CAR T?
I think this is one of the bigger concerns for referring doctors is what am I going to be responsible to do when the patient comes back to me? A, is the patient going to come back? And B, what will I need to do? And that sounds a little complicated. I'm not sure I want to learn some complicated new management. There needs to be a smooth and two-directional handoff that happens when the patient is done with the acute monitoring at the CAR T cell center and then goes back to their referring physician. So at our center and at the vast majority of CAR T cell centers, we send the patient back, and usually that's after 4 weeks post CAR T cell treatment, and there's a handoff. At our center, we have a letter that's got a template of the patient had this treatment on this date and had these complications and is on these medications and needs to do these tests, and basically kind of gives a recipe for how to manage this patient so that it's simple. This is not something that we're saying, look up the manuscript or, figure it out yourself. There's very clear instructions for what we've done for the patient, as well as what we anticipate might occur in the next few weeks, and therefore what should be checked or what medications might be considered. But I think the most important part of that handoff is a phone number saying, please call us. Please reach out to us if there's any issues, because we want this to be a beneficial thing both for the patient as well as for the referring physician, so that that next patient that comes into the front door of the office, and maybe this person's a borderline candidate, I'm not so sure, there'll be an easy decision to say, let's send this patient for an evaluation for CAR T cell. So that should be the expectation for every referring physician, is that if you send your patient, they'll hopefully get excellent care at the CAR T cell center. But on the flip side, when they come back, they'll have a clear, detailed instruction and an open door of communication back to the CAR T cell center.
The MRD has become such an interesting and important topic in cancer in general. What's happening in terms of using MRD to our patients' advantage?
Yeah, MRD is a catch-all phrase that I think is sometimes thrown around just to mean a blood-based test to see if your cancer is gone or if there's still a risk. And for some cancers, we know that they're difficult to eradicate. So slow-growing lymphomas historically have been easy to treat, but difficult to get to stay away. For some cancers, though, such as aggressive lymphomas like large cell lymphoma, usually we either eradicate the disease or it will come back, and it can come back with a vengeance that can be life threatening. And we've not really had an MRD test that's been good at predicting for durable response or for risk of relapse for large cell lymphoma. But there is a new blood test called the phased seq blood test, which seems to have a much greater sensitivity to pick up those patients truly at risk of their disease coming back, or conversely, those patients who are highly likely to be cured already and have their disease be gone for good. And there are now a whole new fleet of trials which are looking specifically at patients with blood tests that show they have a positive ctDNA, negative PET CT scan. So by conventional restaging, they're in remission, but they have a positive test that say they're a high risk of disease coming back, including the Alpha 3 clinical trial, which is looking at patients who are randomized to either receive standard of care, which is observation, or a new allogeneic CAR T cell called Semacell. And that study is ongoing across the United States right now, evaluating if this blood-based test can predict for early benefit from a novel CAR T cell versus observation, which is what we do today because we don't use this test outside of clinical trials. So if these new fleet of clinical trials shows promise, perhaps this could be something that we could have access to for our patients outside of clinical trials. And recently, the NCCN guidelines added that using MRD for lymphomas, including aggressive lymphomas, has a lot of potential and is something that hopefully will be something changing our practice in the coming years.
Got to ask you about allogeneic CAR T. What does that mean?
Allogeneic CAR T is sort of similar to autologous CAR T, where you take your own blood cells and make them into weapons. But for allogeneic, you take some healthy donor. You get some college kid who's got fit T cells that did not receive 6 cycles of chemotherapy or did not receive a ton of other treatments. These T cells are fit and ready to go, and they're available tomorrow. These don't require a manufacturing process, which takes 3-4 weeks to have a turnaround time frame. These are potentially available off the shelf, meaning you could get those cells later in the week, just in the same way you could get R-CHOP later in the week, that it wouldn't require a delay. The downside of allogeneic CAR T cells, you could have graft versus host disease, although we've really not ever seen that because these cells are edited in a way to effectively mean that there's no chance of off-target toxicities such as graft versus host, although theoretically is a possibility. But the bigger concern is that because these are not the patient's own cells, they're rejected. These cells do have a short durability, and so therefore you can have an incredible benefit, but you got to get as much benefit as you can, because once that immune system recovers and says, who are these foreign invaders going around killing lymphoma cells? Let's get these guys out of here. The cell's rejected. So it's got great promise, although as of today, there are not any approvals for patients with lymphomas for allogeneic CAR T cells. Hopefully in the coming years, we'll see those.
I have to say, this has been a great review and also just very exciting in terms of what's to come. I want to thank Dr. Jason Weston. Jason, thanks so much.
My pleasure.
Jason is a professor in the Department of Lymphoma and Myeloma, lead of the Lymphoma and Myeloma Service Line, and section chief of aggressive and indolent lymphoma at MD Anderson. I also want to thank all of you for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet on CAR T, please visit lls.org/CE. For any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources. And this is available in English, Spanish, and other languages. LLS also provides other resources for patients, survivors, and their families that can be found at lls.org/support. I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.